Hello, everybody. My name is Panagiotis Doukas. I am a resident in the University Hospital in Aachen for vascular surgery, the Department of Vascular Surgery. So the chronic limb-threatening ischemia is a relevant disease nowadays. Almost every 10th patient with a peripheral arterial disease is going to suffer from this condition. And in particular, no option CLTI refers to patients that that either had previous failed revascularization attempts or are deemed unnecessary for revascularization modalities because of the anatomy or the nature of the disease. The current treatment options for no option CLTI, it sounds a little bit controversial, but there are some alternatives, but that are in investigational basis. Most of the hope is placed in gene and stem cell therapy. There's still not enough evidence to support these modalities in the current guidelines, but we all await future trials on these alternatives. Pharmacological treatment, for example, with prostaglandinoids, have been removed from the guidelines because there was no sufficient evidence to show that they actually help in wound healing and in terms of amputation and in avoiding amputation. Other modalities like the epidural spinal cord stimulation and lumbar sympathectomy are shown to be able to relieve pain in these patients, but still there was no sufficient evidence to support wound healing and the amputation free survival. So this leads us to the next point, the percutaneous deep vein arterialization, and this was the main subject of the project we were working on, the study, the systematic review and analysis that we published at the start of this year. It's also an experimental modality, an experimental treatment option, but shows in its initial phase some promising results. The idea behind it, the principle rests in the idea that if we bring blood, arterial blood, in the venous system of the foot, there could be sufficient oxygenation and perfusion of the tissue so the wound can heal and the amputation can be avoided. pDVA, it's not a new idea. It's an idea that's almost 100 years old, but it has been reinvented through the years, and now we are at the point where it's possible to minimal invasively and percutaneously connect the tibial artery with the tibial vein in order to provide the capillary bed of the foot with oxygenated blood. That's the whole principle, and this is the idea how to promote wound healing and avoid amputation. In the last years, there has been some case series and some interesting trials in this area. One of the most significant ones, or the most relevant ones, was the PROMISE-2 trial, which was published last year in the New England Journal of Medicine. The authors reported the results of 105 patients with no option CLTI and another fourth category of 5 or 6, so patients with wounds, non-healing wounds. And they were all treated with pDVA. They report a 66% amputation-free survival rate in the whole follow-up, and of course that the device is safe and feasible. And almost every second patient managed to achieve a healing stadium, a healing stage for his wounds. So we scrutinized Medline, M-Base, and Central for cases or for trials concerning pDVA, but the exclusion criteria were cases or trials that reported less than 15 cases, and we only looked into patients with wounds, so Rutherford 5 or 6 states. We managed to take 963 records. From these, 5 studies were eligible for the meta-analysis. The findings of our systematic review and meta-analysis Firstly, we reported a 96% of technical success rate, which is quite high, and an overall survival of 82%. The limb salvage rate with the pooled limb salvage rate was 77.2% for the whole follow-up, and the combination or the combined the composite outcome amputation-free survival rate was 87% in the first month and 68% 6 months later, and at 1 year, 65%. And this is very interesting because what we see with these percentages is that the first 6 months are the most is the critical time frame. This is the time where the amputations or the adverse events are happening, and this is the part where the patients are or should be closely monitored. After that, so from the 6 months to 1 year, we see virtually a plateau because we talk about an amputation-free survival for 68% at 6 months and 65% at the end of the year. The next interesting finding that we reported was the reintervention rate. The reintervention rate, well, as a pooled endpoint, was 46%, and most of the reinterventions were device relevant, so they were device associated. There is no sufficient data to look into the details of this reintervention. So why did the patients need, and what exactly was the indication for the reintervention, and what exactly was reintervened? It was not reported in all the studies, but we know from the PROMISE 2 trial that the device had a primary patency rate of 30% and an assisted primary patency rate of 45%, and secondarily procedures to achieve patency were at 64%. That means that the device or the conduit needs to be closely monitored. We need to see when the patients are experiencing problems, or where is the heat flow inadequate, or when there is anything wrong with this connection, and intervene timely or intervene early, so to avoid an occlusion of the conduit. The last thing that we reported in our findings is the complete wound healing, which was achieved in 53% of the cases, a result that is also comparable to these of the PROMISE 2 trial. So pDVA is a feasible and safe technique for patients with no-option CLTI, and it should be considered as a bailout strategy. When everything else doesn't work, or when anything else doesn't work, it should be in the armature of the vascular surgeon as a possibility. It's very important to closely monitor these patients after the procedure, mainly in the first 6 months, because this is the crucial time frame of the adverse events. And also to address problems with the conduit early enough. Also going back to the monitoring program. One main limitation of our trial was the nature of the studies that we included. They were all observational single arm. Of course, to achieve the highest level of evidence, we will need randomized controlled trials with sufficient patients, and of course, with a long follow-up or long enough follow-up to not only see at the short-term effects, but also in the long-term outcomes of these procedures.